When it comes to the clinical presentation and diagnosis of psoriasis and skin of color, there are a number of important nuances. First off, the color of the psoriatic lesions themselves may vary across the spectrum of patients with skin of color. So we use the term erythema as that clinical marker, that clinical sign of inflammation in the skin, and it comes from the Greek word for red. However, in the context of the broad range of skin complexions that patients with skin of color may have, this redness or erythema may not be purely red. We might see shades of violet, shades of red-brown, shades of dark pigment or gray. And so it's important to broaden the color palette, if you will, when assessing for erythema associated with psoriasis and skin of color. As with any population, psoriasis can commonly affect the scalp, the ears, the face, the nails in patients with skin of color. But one particular nuance when thinking about our patients with skin of color presenting with psoriasis in these highly visible areas is that there can be variations in hair care practices and hair structure and cultural perceptions of skin and hair health that can add to the overall impact of psoriasis when it affects these areas. In addition to the primary lesions of psoriasis, in patients with skin of color, there are often pigmentary sequelae, meaning that once the scaly plaque of psoriasis resolves, it tends to leave behind an area of either hypopigmentation, so reduction of pigment, or hyperpigmentation, increased pigment. And this can be quite long-lasting, in the order of many weeks to many months. It might even be years as one psoriasis plaque resolves and a new one develops. Each time, there may be a new persistent area of discoloration.
Patients can actually mimic lichen planus, lupus, and several other conditions. So oftentimes you need to do a biopsy. There can also be a different tenor and areas that the psoriasis may preferentially affect. Areas of the scalp can be heavily keratinized as well, so you can have very distinct presentations to the disease.
In women of African descent who would naturally have afro-textured hair, there are variations in hair washing frequency and hair structure, and that in turn can sometimes lead us to see thicker plaques, more scale, which in turn can have significant quality of life impact on such patients. When it involves the face, pigmentary alterations, including hyper or hypopigmentation, add to the burden and quality of life impact of psoriasis in patients with skin of color. There are also other scaly red rashes or papulosquamous diseases, as we say as dermatologists, that we include in the differential diagnosis and might mimic psoriasis. This might include conditions such as lichen planus, sarcoidosis, lupus erythematosus, and other conditions. All of these conditions might have features that might resemble, in part, some of the features of psoriasis. There are cases where those conditions are misdiagnosed as psoriasis or vice versa.
Sometimes the diagnosis can be delayed for months or years, and a delay in diagnosis can lead to a delay in initiation of therapy. A lot of studies have been performed showing that skin of color patients in psoriasis, as well as other conditions, oftentimes have delayed diagnosis and delayed treatment as well.
So it's important that one sees a dermatologist who can differentiate these subtle features. There are some factors that might contribute to delays in diagnosis or missed diagnosis or under-assessment of the overall severity of psoriasis in patients with skin of color. Some of the factors are quite multifactorial with respect to delays in diagnosis. It includes disparities in access. It includes lower public awareness in many communities of color about the diagnosis of psoriasis and the importance of seeing a dermatologist for its treatment. But another factor may be familiarity on the part of some healthcare providers, depending on their level of experience, detecting some of the clinical features that are more common in patients with skin of color.
There's a big educational gap in psoriasis and skin of color patients, and the number one gap is that not all dermatologists have practiced and done their residency training in a very diverse environment and seen all types of skin types and skin tones. And if you don't have training that is diverse, then it's going to be difficult for you to identify these patients properly in your clinical practice. So a big gap is actually clinical images also, which can be a proxy, which can really help educate.
It's really through education of our medical students and residents and practicing healthcare provider community that we can help with early and accurate diagnosis of psoriasis for all patients. Historically, many psoriasis trials did not enroll a large proportion of patients who were self-identified as any of the non-white racial ethnic groups. And so in turn, we've had very limited data on psoriasis therapies for patients with skin of color. Thankfully, this is changing, but we continue to make efforts to have studies that are more inclusive and representative of the demographics of the US population.
We need more images of psoriasis across many different types of patient race, ethnicity, genders, ages as well. These are all important factors that we need. Dermatologists are so visual. If we can see those pictures of psoriasis and see, especially in skin of color patients, that can be very helpful to be able to identify a patient properly.
Why is this important? Well, this helps us better understand safety and efficacy and quality of life variations that might exist across different populations.
Skin of color patients oftentimes have a delay getting treatments and therapeutics, so there are significant disparities at every aspect of the process. Access to healthcare is very difficult, and then also proper disease recognition is going to be very important, having that education on images and being able to better understand and identify what psoriasis in skin of color patients looks like, and then also knowing that you need to initiate therapy early. You can't wait. In skin of color psoriasis patients, the big morbidity that may not be present in other patients is dyspigmentation. So if someone has psoriasis for many years, unchecked, uncontrolled, doesn't get proper therapy, especially with the great biologics that we have available now, they can have permanent or long-lasting dyspigmentation that can take a very long time to improve.
In studies that look at quality of life impact of psoriasis, instruments such as the Dermatology Life Quality Index, or DLQI, we see that scores on this validated metric that measures quality of life impact of skin disorders, we see higher scores, meaning a greater impact on one's quality of life in various populations that have skin of color, including those who self-identify as Black or African American, those who self-identify as Asian, those who self-identify as Hispanic or Latino. Why this might be is still not entirely clear, but we can suspect that probably at least one factor is the post-inflammatory pigment alterations that patients with skin of color and psoriasis also have to endure. So in addition to the scaly erythematous plaques, which may sometimes be itchy as well, once those resolve, there's the additional burden of long-lasting light or dark spots, which certainly contribute to patients' quality of life. Something that is very important for patients to understand is that we as dermatologists have expertise in diagnosis and treatment of psoriasis, and we're very fortunate to have a very broad range of safe and efficacious or effective treatments for psoriasis, whether it involves the scalp, the skin, in visible areas or non-visible areas. Another issue that I think is important for patients to understand is that while psoriasis is a skin disease, its impact can go beyond the skin. About a third of patients can develop involvement of the joints, which we call psoriatic arthritis. There are also higher risks for health issues, including diabetes, obesity, cardiovascular risks. And the more we study, the more we learn that there are effects of having psoriasis beyond just the skin. And so it's important to first start with a dermatologist who can then help treat psoriasis on the whole, starting with the skin, but also working together with primary care physicians, rheumatologists, and others as needed to give holistic care for this chronic immune-mediated condition that affects patients of all backgrounds. And the more studies that are done to explore this, we learn that there are more and more effects of having psoriasis beyond just the skin. We're very fortunate to have a range of therapies that can address psoriasis. And so I would hope that patients not delay in seeing a dermatologist so that they can get the most appropriate therapy.